Welcome, everyone. My name is Twin. I am Community Health Resource Center's program manager, and we are hosting the Sutter Health CPMC's breast health team here today.
Thank you so much, Twin, for that introduction, and we really appreciate your support. I'm really excited. This is actually the 4th year now that we have been doing advances and innovations related to breast health, breast cancer, and breast reconstruction. And we're really glad all of you are joining us virtually for another year, but hopefully we'll be back in person next year. You're going to hear a little bit more from Dr. Bokelman, but I'm really excited to be a part of our breast health and breast cancer program here at CPMC. The program here is centered around the Breast Health Center. It's the largest breast imaging center in Northern California with over 44,000 imaging exams and procedures per year. And one of the things I think is particularly impressive about the program is how well coordinated all of it is from a multidisciplinary standpoint. You're going to hear a lot from each of us about the different disciplines that we bring, and we all meet regularly to focus on how we can provide comprehensive care for our patients. Additionally, this is one example, but we're very focused on community outreach and education and are always excited to be able to be providing programs like this to our patients. And certainly for Breast Cancer Awareness Month, we're all involved in multiple different presentations that will be recorded and available should you like to see some others as well. I wanted to briefly talk about our patient care pathway here at CPMC, just thinking through what it looks like if you have been diagnosed with breast cancer and what the whole process would look like. We have a comprehensive risk assessment and screening model here. You'll hear more about that from Elizabeth, our genetic counselor. But you see here that it goes through steps from a process standpoint. We have our risk assessment and screening. And then if we find out you are at higher risk, then you're going to be referred in one direction. If you end up needing a biopsy and having a new cancer diagnosis, we all are involved in multidisciplinary tumor board that has all different aspects of providers from a treatment standpoint represented. And then we move on to part of our survivorship program. That's something that Dr. Dolezal is very involved in and helps run, and then probably hear more about that from her as well. Very excited to have all of our panelists today. So we're going to start with Dr. John Bokelman, who co-directs our breast imaging center, Elizabeth Carte, who's one of our genetic counselors, Dr. Milana Dolezal, who's a medical oncologist specializing in breast cancer and survivorship. And then I am a breast and plastic surgeon, in addition to being the co-director of our breast cancer program. As you heard from Twin, we're going to try to save our questions until the end of each talk, but I'll keep an eye on the Q&A section if you want to put in any questions there or raise your hand, and we'll try to get to each question, all the questions after each panelist. I'd also like to thank our sponsors. We're fortunate today to have both Sientra and Nutrell sponsoring today. They are both breast reconstruction companies that really help us support our patients through their breast reconstruction journey, and we appreciate their supporting us today. Additionally, it is Breast Reconstruction Awareness Day. We try to have this event be focused on breast health and breast cancer as well, but also excited to be doing it on a day where we really celebrate trying to make sure that people know all of their options for breast cancer treatment. And then certainly, of course, want to thank Twin and her team who are so incredibly helpful for supporting all of the work that we do from an educational standpoint and coordinating. So with that, I am going to pass it on to Dr. Bokelman, who is going to talk to us about things from a radiology standpoint. So thank you so much, John, for jumping on.
Right, I should be able to share the screen now. Are you able to see the first slide here?
We are, thank you.
And you can hear me, okay,
yep.
Good. Thank you for the opportunity to participate in this event and give a brief overview of some advances in breast cancer screening and diagnostic imaging. As Ann mentioned, I'm one of the co-directing radiologists here at the Breast Health Center at CPMC. And, oh, I'm getting a strange message here. Let's see, stop. This will stop others. Getting a message says, this will stop others screen sharing. Do you want to continue?
I think you're good to say yes.
Okay, continue. All right. Can you still see my slide?
Yes, we can't see you anymore, but we can see your slide.
Okay, here we go. Yeah, well, anyway, I'm going to give a brief overview of some advances in breast cancer screening and diagnostic imaging. And as many of you know, the CPMC Breast Health Center moved earlier this year to the Pacific Heights Outpatient Center here on Buchanan Street. We have all new state-of-the-art screening and diagnostic breast imaging equipment in a completely remodeled center. For those of you who have not yet visited, it's on the second floor of the renovated building that used to be the CPMC hospital, and it's very close proximity to many of our breast surgeons and medical and radiation oncologists. To start, I'd like to give a brief overview of some basic facts about breast cancer. It's the most commonly diagnosed cancer in women in the United States. About 1 in 8 women will be diagnosed with breast cancer at some point in their lifetime. That's approximately 12% of women. Most of us know someone who has been affected with this disease. It's estimated there'll be about 331,000 new cases of breast cancer diagnosed in 2021. And also estimated that more than 43,000 women will die from breast cancer this year. It's the second most common cause of cancer deaths in women behind lung cancer. Lung cancer, it's estimated there'll be approximately 62,000 deaths in 2021. And there's about 3.8 million women living in the United States with breast cancer that have either completed treatment or are currently being treated. So it's very common. The bad news is it's very common, but the good news is that through early detection, through breast cancer screening, results in improved outcomes with fewer deaths from breast cancer. The death rate for breast cancer has decreased about 1% per year in the interval from 2013 to 2018, and it's thought that this is a result of advances in breast cancer treatment and then early detection through breast cancer screening. And currently, the Society of Breast Imaging and American College of Radiology recommend breast cancer screening starting at age 40 with a screening mammogram every year. This conservative approach emphasizes saving the most lives and maximizing life years gained through early detection. So if you haven't already done so, please schedule your yearly screening mammogram. And if your lifetime risk for breast cancer is high, meaning greater than 20%, talk with your physician about considering adding MRI to the screening exam. Just a word on terminology. Screening means that we're testing asymptomatic women to find breast cancer before it becomes palpable. And a screening exam, everyone gets the same screening exam. It's 2 standard views of each breast. Diagnostic imaging means that we're testing to further characterize an abnormality that was seen on a screening exam or to completely evaluate an area of clinical concern like a lump or nipple discharge. And that usually involves additional mammogram views and possible ultrasound. Before mammography, there was no breast cancer screening. Breast cancer is presented only when they were palpable and larger than what we find with screening exams. Mammography has undergone an evolution over the years, and that continues. And the goal of screening is the detection of breast cancers before they become large. On the screen you see here on the left-hand side, this is from back in the 60s and early 70s, where when mammography started out, it was x-rays just exposed directly onto film. The contrast resolution was poor, and it was a relatively high radiation exposure. That moved on to something called zero mammography, which was an improvement. This was in the 70s and persisted in the 80s, where it detected calcifications well, but had a moderate radiation exposure dose. In the 80s, developed something called film screen mammography, which markedly reduced the any radiation exposure to the breast. It really became a low dose exam. And this was also able to come at a very high resolution. And then over since about the late 90s, early 2000s, we've moved on to the digital world that we have now, digital full field digital mammography. And it offers the same high resolution imaging at the same very low dose exposure that film screen was able to do. And so on mammography, well, the breast is composed of fibroglandular tissue and fat. And at mammography, fibroglandular tissue appears white and fat tissue appears dark. Here you got a picture of the sky with clouds floating across. Here on the right-hand side is an oblique view of the breast. The darker area is a fatty tissue. The kind of wider splotchy areas are fibroglandular tissue. And the higher the percentage of fibroglandular tissue in the breast, the more challenging it is to find small breast cancers. And this kind of cartoonish star right here is supposed to kind of represent what might be a cancer. It's white, but cancers actually aren't that white. They're the same density as the fibroglandular tissue. So the denser breast tissue becomes the more challenging it is to find smaller cancers. And just an example of that here on the right-hand side is a breast composed mostly of fatty tissue, dark tissue, very limited fibroglandular tissue, and there's a small little cancer that we can very easily see. Arrows nicely pointing it out. Here on someone with a bordering on extremely dense fibroglandular tissue, there's a fairly large tumor up at the upper posterior glandular margin that is very difficult to see. You can see a contour abnormality, and there's some tip-offs. This would be picked up, but to an unexperienced eye, it would be very easy to walk right over it. And it's very difficult to see. So that brings us on to digital tomosynthesis. And breast 3D tomosynthesis, it's the next step in the technology advancement for mammography. And it's poised to become the standard of care in breast cancer screening and diagnostic imaging. A standard 2D digital mammogram. One view consists only of one image, and here I'm kind of, this is go back here, where I have the arrow circling around. This is a standard digital mammogram. It's an oblique view, and this view consists only of one image. Now in the middle of the screen is a 3D tomosynthesis study. I can't show you a cine loop on this, but one view actually consists of a series of 1 millimeter thin sliding images through the full thickness of the breast. So if this breast, say, compresses to about 6 centimeters when the picture is taken here on digital mammogram, we just get one image. On the digital tomosynthesis, we get 61 millimeter sliding images. That's okay. And the arrow is pointing to kind of this abnormal area that's actually on a diagnostic screen, very easy to see. This is a blow up of that abnormality. There's a small mass with spiculated margin. It's a small tumor that's surrounded by very dense fibroglandular tissue that we can fairly easily see on digital tomosynthesis. Again, it's not really detectable at all on the standard 2D image. And the advancement of tomosynthesis results in increased cancer detection rates, and it reduces false positive recall rates that are caused by overlapping dense fibroglandular tissue. The tomosynthesis unit looks just like a standard mammography unit. The only difference being that here at the very top is the X-ray tube. Instead of staying stationary, it makes an arc with a series of very low dose exposures over the course of that arc, and then a computer reconstructs the images of 1 millimeter thick cuts. And to demonstrate again the advancement that this brings, here on the left-hand side is a cranial caudal view of the breast. There's a vague density where this arrow is pointing to, but on the 1 millimeter thin tomosynthesis cut through the area of the abnormality, you can see there's a mass with a spiculated margin. This is the same breast looking at it from the side. Again, there's a vague density where the arrow points to the 1 millimeter thick cut in the plane of the abnormality. Clearly shows a cancer with a spiculated margin. And finally, here's like a cone down view of a portion of the breast that just again shows a density with the these two arrowheads. The 1 millimeter thin cuts clearly show there's a mass there with kind of a well-defined margin. So it's pretty easy to see that tomosynthesis is a significant advance. And as I mentioned, it's poised to become the standard of care. The issues with it have to do, they're very costly machines, and they're not readily available throughout the country. They're being just due to cost. Likewise, but they are becoming much more readily available. And here at CPMC, all of our mammography machines have the latest 3D tomosynthesis technology, and all mammography exams we perform here consists of, we use tomosynthesis. So it's been a significant improvement. I've mentioned that increasing fibroglandular density can limit the sensitivity of mammography due to overlapping tissue. Breast density is based on a visual assessment by the radiologist, and it's included in every report. We categorize the breast in 4 categories, ranging from fatty to scattered fibroglandular densities. This is considered average or not dense breast tissue. And then heterogeneous dense and extremely dense is considered dense breast tissue. And 50% of women fall into the, they get a letter stating that you have dense fibroglandular tissue. And more or less that's to inform patients that of the case that their breast tissue is dense, and that it's makes it a little harder to evaluate the results of the mammogram. And it's also associated with a mild increased risk for breast cancer. So there's, again, tomosynthesis addresses a lot of the issue that the breast density does, but when you're getting into a breast that is extremely dense, which is about 10% of women have extremely dense breast tissue, 10% of women have fatty breast tissue, and 80% of women fall into these two middle categories here. So but breast tomosynthesis has clearly been shown to increase cancer detection rates and decrease false positives in all categories of breast density, but most notably in the dense breast categories. And so I'll just move on to breast MRI, another modality that we use both for screening and for diagnostic imaging. It's a non-invasive test that uses a very strong magnetic field and pulsed radio waves to manipulate the magnetic properties of tissues. It does not involve any ionizing radiation, but it does require an IV contrast injection. And MRI evaluates both the anatomy and blood flow pattern. And cancer develops usually as a mass, and it also develops new abnormal blood vessels. And it's these blood vessels that avidly enhance and really allow us to have a very high sensitivity for picking up breast cancers on MRI. Some of the, there's several other indications, but the common ones are if someone has a high lifetime risk for breast cancer, which we categorize as 20%, and they have dense fibroglandular tissue, which again, mammography is a little bit hampered with, adding breast MRI into supplemental screening in addition to mammography is recommended, just because of the incidence of cancer in that group of women would be high, and we would want to, again, we're trying to find cancers when they're very small. And then we commonly use MRI to evaluate cancer extent in patients that have been diagnosed with cancer for treatment planning, and then also monitor breast cancer response to neoadjuvant chemotherapy for treatment planning. patients that are kind of considered high risk that should consider adding breast MRI in addition to mammography. Genetic mutations, BRCA1, BRCA2 gene mutations, and some other genetic mutations that have a much higher risk for breast cancer. A woman that would have a first-degree relative of a mutation character, but the woman is untested, she would have a higher risk. There's online risk calculators that you can very easily find that would help determine what your risk for cancer is. Usually to be up above the 20% range, though, you have to have a first-degree relative that has been diagnosed with breast cancer or a genetic mutation. There's other women that having had chest radiation therapy when you're younger than 30 years old, strongly increases the risk for breast cancer. If you've been diagnosed with breast cancer and have dense breast tissue, again, dense breast tissue kind of slightly limits even tomosynthesis. So consider adding breast MRI. And then women that have been diagnosed with breast cancer prior to age 50 is another group. I'll quickly roll up. I think my time's expired. So here's an example of a breast cancer that was easily seen on mammography. It's enhancing. That's the whiteness means that it's the contrast enhancing. We use a computer to aid us in evaluating the vascularity of it. Here you can see some color over in this other breast that's blue. This is just normal vascularity. This mass has abnormal blood vessels that wash out too rapidly. So that goes certainly along with breast cancer. What the value of this, though, is that it shows 2 additional lesions that were further than 2 centimeters away from the primary mass that were not visible on mammography or ultrasound. So by using breast MRI, it helped to include these areas that were also malignant in the treatment, as opposed to taking just the obvious tumor, only the obvious tumor out. Here's another example of a mammogram showing kind of the woman has a palpable lump in the upper outer quadrant of this left breast. The arrows point to this area of increased density. This is a 2D digital mammogram. And so that it's abnormal, but it's just a vague density. We can see 2 enlarged lymph nodes up here in the axilla. Ultrasound, it shows there's a 3 centimeter hypoechoic mass. But on breast MRI, it shows that the area is much larger than 3 centimeters. Again, it's having this information that really aids in surgical planning, because due to the size of the tumor, that altered the treatment planning or surgical planning. And finally, here's just a small tumor kind of in the middle central portion of the breast. On ultrasound, appears as a dark hypoechoic mass. On MRI, it's in the middle portion of the breast. But then breast MRI showed another enhancing lesion that was malignant in the deep posterior outer portion of that same breast that, again, was not evident on mammography or ultrasound. So again, this changed the surgical management in this case. So in summary, unfortunately, breast cancer is very common, but the good news is that early detection through breast cancer screening results in improved outcomes with fewer deaths for breast cancer. And we recommend breast cancer screening starting at age 40. If you haven't already done so, please get your yearly screening mammogram scheduled soon.
Thank you so much, John. That was so helpful. And I really appreciate all the discussion around dense breast and MRIs and 3D mammograms, because I think those concepts are really complicated and rapidly evolving. We have a great question here that I was going to ask also, which is the question about breast ultrasound for screening. And, it continues to come up from patients, and some places recommended for high risk patients and others don't. And I wondered if you just could comment on kind of what we do here at CPMC and your thoughts about whether or not breast ultrasound plays a role in screening.
Well, breast ultrasound does play a role in screening. It's not, it's a little bit in the evaluation stage. It does clearly show some cancers, an incremental increase in cancers that we do not see on especially dense breasted women. However, if somebody gets into a higher risk category, breast MRI has a much higher sensitivity than than ultrasound does, and it's been shown that anyway, through a series of things, that breast MRI is the most sensitive way to detect the most cancers. And that would be the best way to approach a woman that has high risk for breast cancer, that has dense breast tissue. Ultrasound will show an incremental increase. However, that also comes at the cost of doing many more biopsies. To come up with that, with those additional fewer. So at the end of the day, we are not alone as the institution. We kind of follow guidelines, and the current recommendations are that and we use tomosynthesis on all patients here. So that's another thing. Not all sites have tomosynthesis. So I think the combination of tomosynthesis plus MRI is what we choose as the way to go. Screening breast MRIs are not reimbursed by insurance companies uniformly. They maybe are some places, but that has been an issue. So there's a variety of things. So.
Great, thank you. And just so everyone knows, we were talking about screening, but certainly we do use ultrasound for our diagnostic tools here. There's a question from an attendee about mammography detecting lumps in the armpits. And I hope you feel free to jump in, but my thought about this, John, would be, that would be a great scenario where we would be using ultrasound if someone came in with a lump in the armpit they were worried about. And so it can be a really good diagnostic tool in that setting.
Yes.
One last thing, Elizabeth, if you want to go ahead and start sharing your screen, that would be great. But John, I did have one last question, was just to confirm, someone asked about contrast MRIs and just wanted to confirm that for a breast cancer setting or breast cancer screening setting, we would be doing contrast in all of those cases?
Correct. Yes. Breast MRI without contrast does not screen for breast cancer.
Great, perfect.
We'll do it for implant evaluation. It lets us see back to the chest wall, but we need contrast.
Great, thank you so much. Thank you for that great talk. Okay, we're gonna move on to Elizabeth talking about breast cancer risk assessment and genetic testing.
Great, thank you. Are you seeing my screen okay?
Yep, it looks great.
Okay, perfect. So thank you. I'm Elizabeth, and I'm here to talk to you about risk assessment and genetic testing. So by this point, I think we've all seen some iteration of this infographic. 1 in 8 women in the US is expected to develop breast cancer in their lifetime. It's the second most common type of cancer that women get, following skin cancer. And what that means, like Dr. Bokelman said, is that on average, each woman has around a 12.5% chance of developing breast cancer. And because of that risk, every woman is recommended to undergo breast cancer screening, regardless of personal or family history of cancer. But when we look at this 1 in 8, we think, well, who is the woman that's going to get breast cancer out of these 8? And how can we use our tools and our understanding of cancer biology to understand this risk before someone's diagnosed with cancer, so that we can either do more to prevent, or it can lead to an earlier diagnosis. So before we can answer that question, let's think about what we do know. There are many risk factors that influence breast cancer. Some of these we can control, like lifestyle factors such as alcohol consumption, dietary fat intake, smoking, exercise. And then there are environmental exposures such as radiation or certain chemicals. There also are way more factors that we can't control. Just being female is the biggest, and that's at any point. So cisgender woman, transgender man who went through puberty as a female, transgender woman on hormones. Age is a risk factor. Reproductive factors, so having your period before age 12, late menopause, so menopause after 55, when the age that someone had their first child, Ethnicity can be a risk factor. Being Black, a family history of cancer is going to influence your risk, as well as your genetics. And so when we think about breast cancer risk and screening, it's important to incorporate all the pieces of this puzzle. When we perform a risk assessment, or when we're trying to quantify someone's personal risk of breast cancer, we're going to collect a comprehensive family history. And that means we're going to look at 3 generations of family members. So grandparents, parents, aunts and uncles, siblings, cousins. We're going to ask about those who've had cancer, what type of cancer it was, how old they were. Do you know any specifics about treatment? We're also going to ask about those who haven't had cancer. How old are they? Have they had any preventative surgeries, such as a hysterectomy for fibroids, for example? We're going to ask about ethnicity. We're going to ask if genetic testing has already been done in family members. And then we're also going to take into account your personal medical and surgical history. So have you yourself had cancer? Any skin biopsies or breast biopsies, colon polyps? What type of exposures have you had? Different carcinogens or hormones? We're going to go back and ask about that reproductive history. So again, when you had your period, menopause status, children, and then of course, have you yourself done genetic testing? And if not, that's something that we'll typically do. And then we put all that together, the personal and the family history, to help someone understand their risk and what their screening plan should be. So looking at all of that, are they high risk due to a genetic mutation that we identify? And if so, we can recommend personalized prevention and screening based on that gene and the associated cancer risk. Or maybe they fall into the familial category. So there's no mutation in the family, but there's still more cancer than we'd expect just based on chance. And then depending on personal risk factors and exposures and family history, we might still recommend additional cancer screening. Or maybe there's nothing out of the ordinary. There are no cancers, relatives live to older ages, and great, that's reassuring, but we still want to recommend cancer screening based on general population guidelines. And so typically that's screening for breast cancer, as we just heard, starting at age 40 with your mammograms, screening for colon cancer with colonoscopies, possibly skin cancer or prostate cancer screening for men as well too. And so looking at that first category, the hereditary category, I want to spend a little time there. I'm a genetic counselor, so I have to talk about it at least a little bit. Most of the time, cancer isn't genetic. Only about 5 to 10% of the time when someone is diagnosed with breast cancer, do we actually identify an associated mutation. But who's more likely to fall into that 5%, 5 to 10%? And that's families where we see certain features. So cancers that are diagnosed at younger ages. And when we're thinking of a younger age for cancer, we're typically thinking before age 45. We look for certain patterns of cancer types. So are we seeing breast cancer, ovarian cancer, and pancreatic cancers? Those are common ones that we can see together with some of these hereditary breast cancer syndromes. We look to see, are there multiple cancers in the family or multiple cancers in the same individual? Especially if we have multiple generations of family members affected too. Again, we're always going to ask about different ancestral groups, and then is there a known mutation in the family? And so just to give an example, the most common hereditary breast cancer syndrome results from a mutation, pathogenic or disease-causing mutation in the BRCA gene, or BRCA. And BRCA stands for breast cancer gene 1 and BRCA2, breast cancer gene 2. These were the first genes that we identified to be associated with breast cancer, and they're still 2 of the most common genes that we do identify. They're also 2 of the higher risk genes, so they have higher cancer risks associated. Looking at this little chart, you can see that women who have a mutation in one of the BRCA genes has up to a 60% chance of developing breast cancer. And in addition to your first diagnosis of breast cancer, we also see that these women are more likely to get breast cancer for a second time. So maybe in the other breast or maybe in a different location, around 40% of women will go on to develop a second breast cancer. We also see increased rates of ovarian cancer. We see that men are more likely to develop breast cancer. Men are also at an increased risk of prostate cancer. And then melanoma can be increased, and in certain families, we also see pancreatic cancer. BRCA isn't the only gene, and with advances in technology, we often will test for multiple genes at the same time. And genes are typically categorized based on either the cancers that they're related to, so we can think about the breast cancer genes, the ovarian cancer genes, or we can think about them based on the degree of risk that they confer. So looking at this chart, what you can see here is the first few are our high-risk genes. And it's always going to be a range that we're going to get. It's not a hard 60%, it's 60 to 70, 60 to 80, for example. So we have a couple high risk, then we have some moderate, and then we have some low risk genes. But all of these, as you can see this dotted line, they're all above a 20% threshold. And that's what we use to recommend doing additional screening. So maybe that's screening with MRI, like we just learned. And then to help demonstrate how we use this information, I have an example for you. And so what we see here, this picture of these circles and squares, this is what we call a pedigree. It's how we record a family history. And you can see this is 3 generations. So up here, we have our grandparents, and then we have parents, aunts and uncles, and then this is our patient. The circles are women. And so my patient was 37 years old, and she came in because of her family history of cancer. Her mom was diagnosed with breast cancer at 35. Her grandmother, maternal grandmother, had breast cancer at 60. And then on her dad's side, we have stomach cancer at 75 in her grandfather. She also has one aunt who passed away at a young age due to a car accident. That's her mom's sister. And another maternal aunt who's in her 70s and hasn't had cancer. So we did testing. Her mother wasn't available for testing and found out that she has a mutation in a gene called CHRC2. And CHRC2 is a relatively common gene that we see in women with breast cancer. It's present in about 1 to 2% of women that have breast cancer. It's more common in people from Northern and Eastern European countries compared to North America. And it helps with DNA repair. So when it's mutated and it's not functioning properly, individuals are more prone to develop cancer. And specifically, the ones that we see are breast cancer, colon cancer, and possibly even thyroid and prostate cancer. So we talk about these genes, and now thinking about what she should be doing, because we know she has an increased risk of breast cancer, she was recommended to do an annual MRI in addition to her mammogram. So she does both each year, alternating them every 6 months. And then even though we don't see colon cancer in her family, we know that she does have an increased risk just based on this gene mutation. So the recommendation for her is to begin screening with colonoscopy at age 40, which is earlier than average. Typically it's around 45 or 50. And she's going to do them every 5 years as opposed to every 10, assuming nothing atypical is identified. We don't always find a genetic mutation that explains why someone develops cancer. Only 5 to 10% of the time it's hereditary, right? So most likely that's because there are so many causes of cancer: environmental, lifestyle, smaller genetic. And so when we see a pattern of more than 2 first or second degree relatives, first degree relatives would be a parent and a child, it would be 2 siblings. A second degree relative would be, an aunt and a niece, or a grandparent and grandchild. So when we see that pattern and genetic testing is negative, we still want to pay extra attention to that family. And that's because we know that the risk of breast cancer increases as you have more close relatives that are diagnosed with cancer. And so to look at an example of that, this is a family where I ended up seeing a couple relatives. So first I started with this woman here, and she came in because she was 50 years old and she had just been diagnosed with breast cancer. She has 2 sisters that have never had cancer, as well as an older sister who had breast cancer at 48. Her mom is 70, no cancer. And then on her mom's side, she has another aunt who had breast cancer at a young age. So we did genetic testing and it came back negative. So, that's reassuring. And it suggests that her cancer is not due to a single gene or a hereditary form, at least not one that we've discovered yet. It also suggests that she doesn't have an increased risk for another type of cancer like ovarian or colon in the case we saw before. But what about her family members? For her sisters or her nieces and daughters, what should they be doing for breast cancer screening? So to think about that, the first question would be, have the other two family members with cancer had genetic testing? In this case, they had. Her sister was negative, her aunt was negative. And so then we can go back to those other personal characteristics. And so this sister actually ended up coming in, and we have some information on her about when she had her period, how tall she is, what her weight is, when she had her first child, her breast density that we just heard about, her ancestry, and hormone use. And using all of that information, we were able to see that her risk of breast cancer is increased. But we're able to put a number on it, which helps us with determining what the optimal screening plan should be moving forward. So looking at this graph, just to orient you, the blue is the population risk. So that's the risk for an average woman at age 48. And then this red line is this individual woman's risk, her personal risk, based on her family history and all of those personal characteristics we just entered. And so her lifetime risk of breast cancer is almost 34%, and that's compared to about 10% for someone her age. And then in the next 10 years, her risk of cancer is around 9.5% compared to just 2.5%. So for her, she has a couple different options. In terms of screening, we're definitely going to recommend that she talks about adding a breast MRI every year into the mix. Again, 2 different images twice as often detect more cancers. And then because her risk of cancer in the short term is elevated quite a bit, she can consider taking chemoprevention as well. So different medications that can be used to lower her risk of cancer. And that's something that we meet with an oncologist to discuss. And so, looking forward, what's on the horizon? How is risk assessment? How is genetic testing going to change? There's so much that's changing and evolving. We're discovering new genes associated with hereditary cancer risk often. And even for the genes we have discovered, we're still learning more about the risks associated and what the optimal screening plan should be. We're looking at new ways to personalize someone's risk for developing cancer too. So like I mentioned, genetics is only one piece of the puzzle. So there are more sophisticated tools being developed that incorporate factors such as things that we call polygenic risk scores. So these are how smaller genetic factors work together to influence your risk. Basically, if you just sample throughout someone's genome. We are also factoring in how negative genetic test results work, how family history works. So those models are always becoming a little bit more sophisticated. Our testing technologies are changing too. We're able to test RNA, which is a little bit, so you have your DNA, which turns into your RNA, which turns into your protein. And by testing RNA, it's a little bit closer to that final protein product, and we're able to identify some mutations that previously were missed. We also are doing paired germline and somatic testing. So with certain types of tumors, we can look at the tumor itself, see if there are any mutations in the cancer, which can be helpful for the oncologist to help determine what the best treatment can be, but it also can give us insight into potential hereditary components to that cancer. Screening and prevention techniques are changing too. We just learned about how mammograms have evolved so much. Prevention techniques, preventative surgeries have evolved. And then novel treatments are being developed as well that can be more targeted based on genetic mutations. And the goal with that is really just to hopefully be easier on the body and lead to better outcomes. And so to end this talk, cancer doesn't have a single cause. Even when it's hereditary, there are still other factors at play. But by using our knowledge of these personal risk factors and family history and genetics, the goal is to identify individuals who can benefit from additional cancer screening. And this, we know, leads to better outcomes. And then lastly, genetics is always evolving. I expect over time, we're just going to have better technology for identifying mutations, more information about different inherited cancer risks, and better ways to treat and prevent cancers. So thank you for listening.
Thank you so much, Elizabeth. So comprehensive, and it's so helpful. I think, especially seeing the pedigrees and helping people understand, who would benefit from genetic counseling and testing, and how we can think about that is incredibly helpful. I wanted to ask a question that comes up sometimes, which is about insurance coverage. So can you talk a little bit about a couple of things? One, sort of, do people run into insurance coverage issues? How do we think about that if you're a person who wants to be tested? And then the second, which is a little related, but is also, can you run into challenges getting insurance, like health insurance, life insurance, things like that, if you find out you have a genetic mutation? Because that's another thing that sometimes worries people about getting genetic testing.
Definitely. Those are great questions. In terms of genetic coverage for testing, it has come a long ways. It's way more accessible than it was even 5 years ago. Insurance does a good job of recognizing and covering testing when there's a compelling personal or family history. So there's that criteria that needs to be met. And when there's enough in the family, and we say enough, it means typically what we're thinking about is there a 5% chance or greater of having a mutation? And if so, insurance tends to cover it. If not, the cost of testing has come down quite a bit as well. There are many options available to get testing for $250 out of pocket. So when insurance doesn't cover, there are other options out there. The second question is related to genetic discrimination. And I've been seeing that come up less and less in clinic, which I'm taking as a positive sign that people are feeling a little bit better about it. In 2008, there was a law that was passed. And so your health insurance company and your employer can't use your genetic status against you in any way. They can't use it as a pre-existing condition to raise your rates or not cover you, or to fire you or not hire you. We would never tell your insurance company or call your employer and say, hey, we found this mutation. But if a health screen was required for your job, or if we want to do additional screening down the line, that's how your insurance could find out about it.
Great. Thank you so much. I think it's really good for people to hear that, because again, it can be scary for so many reasons to get genetic testing. And I think kind of feeling like that knowledge is power and not something that could be potentially used against you is really helpful to taking that off the table as a barrier.
Definitely.
Well, great, Elizabeth. That was a great talk. Thank you so much. You're going to move on to Dr. Dolezal now. So Milana, whenever you're ready to share your screen and get going.
Hopefully you guys can hear me okay.
Yeah, we're good. Thank you so much.
All right. Okay, let's see. Come on. There we go. Okay, so thanks everybody for coming. I've done quite a few of these for community health resource. So I try to think about sort of what's new and trying to give you a more state-of-the-art type of idea of what's new in breast cancer. And I am a medical oncologist, and so my bailiwick is sort of pills, IVs, the kinds of therapies that go throughout your body, which is different than Dr. Peled, who's a surgeon, and the radiation oncologist. I just want to disclose that I do speak for several different companies. So just an outline here. I'm not sure how much we're going to be able to get through, but there's a couple of take homes I'd like you to think about. So really, we're in an era of cancer biology. It's all about the genes and the pathways, and even less so about sort of where the cancer started. So keeping that in mind, we're also in a nice era where less is more. So I'll talk about some tests that can help understand whether or not you need chemotherapy or not, in addition to how long do you need antiestrogen therapy? Do you only need 5 years versus 10 years, etc. We'll talk about the difference between prognostic and predictive factors. And then an extra passion of mine is targeted therapies and what's new in that field. And if we have time, maybe we can get to another passion of mine, which is really supportive care and what I call cancer thrivership in our cancer survivors. All right, so I think it's important to understand kind of the difference between a prognostic test and a predictive test. And prognostic, this could be on a tumor tissue, for example, a biopsy or the surgical pathology from a breast surgery. And prognostic says, okay, this is a bad cancer, this is not so bad a cancer. A lot of tests out there are prognostic versus a test that's predictive that actually tells you your cancer would benefit from an intervention. And that could be chemotherapy as an intervention, that could be a type of targeted therapy as an intervention, or it could be the duration of therapy that you receive. So I mentioned the biologic century here. So we're really trying to understand the underlying tumor biology. So Elizabeth talked about what's called germline testing, which is your family history, mom, dad, what's in your family that could have contributed to cancer development. But we also test the tumors themselves and sometimes even the blood for different mutations that could help drive the cancer to grow. And so we've already talked about the BRCA testing, but there are a lot of targeted cancer therapies that we use that are targeting a specific type of biology. So when you get your pathology report and it says estrogen positive or progesterone positive or HER2 positive, those are the three sorts of receptors which are on the outside of the cancer cells that we pay attention to. And the reason those are important is we have therapies that specifically target those receptors and how the cancer cells are growing. So antiestrogens like tamoxifen or aromatase inhibitors are examples of that. HER2 agents are examples of that. In patients who have a BRCA positive breast cancer, like Elizabeth had mentioned, there are drugs that are pills called PARP inhibitors that are used. And then now we also use immunotherapy in triple negative breast cancer where ERP and HER2 are negative. We now have the advantage of sequencing the whole genome. And so we have that data available. And I'll talk about these prognostic and predictive platforms. So a lot of scientific breakthroughs in terms of really tailoring your therapy and personalized medicine. So here's just an example in the breast cancer space of some of the gene expression profiles that we use in consideration of how we're going to tailor your therapy. So this is a little bit different than some of the other tumor platforms that are out there that we use a little more commonly in the stage 4 setting. So this is focusing on early stage breast cancer and for adjuvant after surgery types of therapies. So there's the Oncotype DX, which you might have received after your surgery or even sometimes before to understand if there would be a predictive benefit from chemotherapy. That particular platform is also prognostic, and it's in our NCCN guidelines, which are the National Comprehensive Cancer Center guidelines. And then you see other different platforms down there. Most of those are just prognostic. Is this a bad cancer or not? And then the other one I'm going to explain is the breast cancer index, which is specifically predictive for taking an antiestrogen for more than 5 years. So what's the Oncotype DX? So I'm not going to get real detailed here, but just understanding that this is done on the breast tumor tissue, and it's a combination of 16 different cancer-related genes, some of which you already probably have heard about. I mentioned HER2, estrogen, progesterone. There's something else that's on a routine pathology form called Ki67, which is a measure of how fast the cancer cells are dividing. So you can see all the genes there. And this is what's called a PCR test. And it's done on the tumor tissue from a breast tumor. And so what does this tell us? So it's prognostic to say, okay, is this a bad cancer, not such a bad cancer? It's also predictive as to whether or not the cancer that was cut out of your body would benefit from chemotherapy. And this is particularly relevant for younger patients where we know there can be a benefit from IV throughout your body adjuvant systemic chemotherapy, or not. We're not going to treat patients who don't really need it. And this is really a bit of a paradigm shift, because even a decade ago, for example, any lymph node positive breast cancer would get chemotherapy sort of no matter what. And now we're using this Oncotype DX even for patients who have 1 to 3 positive lymph nodes that used to be deemed higher risk, and say, well, you don't really need chemotherapy even though you had lymph nodes that were positive. So that's important in terms of de-escalation. Don't need chemotherapy, has side effects. And then it also can tell you a different way. Elizabeth mentioned sort of DNA, RNA, protein expression. When you look under the microscope, the pathologist looks at the protein expression of estrogen, progesterone, and HER2. Well, this is a different way to look at the DNA level of estrogen, progesterone. So you can see here all the different components of this molecular test that's very helpful, prognostic and predictive. And then you can tell here with even the node positive patients that it's helpful to understand what the risk is. And a recurrence score of 6 is low. So here's 2 different clinical examples. And I like to talk to patients about this when I say, well, how am I going to use this information? And I use a twin example in terms of, let's say you had a sister who was diagnosed with breast cancer around the same time. It looked the same, it was the same size, it had all the same molecular features under the microscope. You both took an anti-estrogen pill, maybe tamoxifen or an aromatase inhibitor for 5 years. Well, your sister's cancer came back, but yours didn't. Well, why was that? And so that's where these gene tests become really helpful in understanding that. So you see here, patient A had a low recurrence score with a low risk of distant disease, even though it was a small tumor, possibly lower grade and lymph node negative. But then patient B, even though it looked all the same under the microscope, actually had a high recurrence score with a distant recurrence. So that could be bone, the breast cancer going to the bone, maybe even 15 or 20 years later, kind of like Olivia Newton-John, or other areas. So this patient B actually had a high recurrence score with almost a 25% recurrence risk at 10 years. And so that's the patient that I'm going to offer chemotherapy to and have a serious discussion about the need for chemotherapy. So that's the idea here with the Oncotype being predictive for chemotherapy benefit. Well, what about anti-hormonal therapy? So IV chemotherapy is one strategy that we use. Well, we use anti-hormonal, so anti-estrogen, progesterone treatments as pills in patients who have an estrogen, progesterone positive, hormone positive kinds of cancer. And it basically blocks hormones from attaching to the breast cancer cell receptors, or decreases the body's production with what's called peripheral production. So younger women can make estrogen through their ovaries, versus older women can still make estrogen a different way with this enzyme called aromatase, which happens outside of the ovaries. And you can see here the breakdown. Most times patients take them for at least 5 years. Sometimes we even use it prior to surgery to shrink tumors that are estrogen positive. Well, so everybody sort of hangs their hat on this 5-year plan of taking this pill. I mentioned Olivia Newton-John from Greece, whose cancer came back later into the bones. Well, so why is that? How can we sort of predict who might benefit from taking an anti-hormonal therapy for longer? And you can see here that even patients who have small tumors, which is this lower yellow line, the T1N0, so those are lymph node negative, possibly 2-centimeter tumors. And you can see at 20 years of follow-up, there's still about a 13% risk of recurrence, like in the bones or some distant site. So it'd be nice to understand, well, who are those people? And on the flip side is, well, what about those lymph node positive patients? Do they always have to take an anti-estrogen to 10 years? So here's really a challenge here to understand, well, who's going to benefit? So if you only have about 5% of patients who might benefit for taking an aromatase inhibitor or tamoxifen for 10 years, well, what are all the side effects? So certainly we know about, with aromatase inhibitors, bone pains, bone density issues. In tamoxifen, there's a small risk of endometrial cancers, blood clots, and then these pills aren't very well tolerated. You can have hot flashes, you can have vaginal dryness, sometimes even some cognitive side effects. And non-compliance rates in terms of taking antiestrogens can be anywhere between 20 and 40%. So if you have half of your patients who are not going to take the pill, well, it's not going to work very well. And this just gives you an example. These are sort of the traditional things on the left side that we pay attention to gauge the risk. And these are what are called clinical and pathologic features, but they don't always predict benefit from extended anti-estrogen therapy past 5 years. So it'd be helpful to have a test that really helps predict that. So here's a test called the Breast Cancer Index. And this is a test that can be done around year 4 or 5 of completing the anti-estrogen therapy. It goes back to the original tumor from the surgery from 5 years prior to give that risk assessment. And different than the Oncotype DX, but it's done on the same sort of tissue, and different genes that are being tested here. And so on the left side here, you can see the predictive genes. It's called H/I, and that gives you an idea of whether or not that breast cancer that was cut out of your body 5 years ago, being on a pill for 5 years, would benefit from more than 5 years of an anti-estrogen. So it's really basing it on the individual's tumor biology and personalized medicine. So here's one of my patients, just to give you an example of how I use this. So I showed you the slide where there was a T1N0, very early stage breast cancer, but a 13% risk of recurrence at 20 years. Well, here's one of my patients who had a 1 centimeter tumor, lower grade 2, highly estrogen positive, HER2 negative. Her BCI test was ordered at about 4 years to understand, okay, well, are we done at 5 years? Oops. Or are we going to stop in the next year? Well, she actually had a predictive result that said she would benefit from taking a pill for longer. And her risk of distant late recurrence was about 8.6%. So these are sort of shared decision-making conversations that you can have with your oncologist to really tailor your therapy. You know, if you have a lot of bone density issues or a lot of side effects, you might not be interested in continuing for longer. But if you're tolerating the drugs, it gives an idea of, well, maybe I should continue this because I've been taking it for 5 years and I want to decrease any chance that this cancer will come back. Here's another flip side. This is a patient who had a lymph node positive breast cancer. And I mentioned years ago, not even a decade ago, we would have given a patient who had 3 positive lymph nodes chemotherapy. Well, she had a lower grade tumor, but she was lymph node positive. So I wanted to know, okay, well, do we need to continue this pill? Because she had bone density concerns. I was worried about her falling down on the sidewalks of San Francisco, maybe breaking a hip. And she wouldn't benefit from taking a pill past 5 years. So that's how we use that information clinically. And again, having the conversation. So what else is newer in hormone positive breast cancer? So CDK inhibitors work on how the cells cycle, the cancer cells cycle. These are pills that you take. This is complicated, but just gives you an idea of where it's hitting the cells. We have used this treatment for many years in stage 4, hormone positive to the bone, stage 4 disease. But just last week, it was approved in the earlier breast cancer setting that's high risk with more lymph nodes positive, about 4 lymph node positive. So now the FDA has approved this combination therapy. It's a drug, a CDK inhibitor called Verzenio, which is combined with an anti-estrogen. So you can look that up. All right, and that was the Monarch E study. that showed that. This was a phase 3 study. And you can see that the disease-free survival, this is a lot of statistic stuff, but basically there was a benefit from adding this medication. So what else is newer in the HER2 breast cancer space? We talked about 1 in 8 women being diagnosed with breast cancer in the US. About 15 to 20% of those patients, generally younger women, have a more aggressive type of HER2 positive breast cancer. This is what a normal breast cancer cell can look like. But when you have HER2 expression, you can see all these extra receptors here. So cells grow quickly and fast and divide. And actually, these are the little HER2 V's or Y's out here. And we have antibody therapies that can target those. So this is also a busy slide, but it just shows you how exciting it is in terms of how many different therapies are available. So trastuzumab has been used since 2005. I used to work at Genentech and worked on the development and the FDA approval of some of these drugs. And these drugs on the left, these antibodies, bind to the outside of the HER2 cancer cell to stop it from signaling. And those are some of the examples on the left. We also have what are called antibody drug conjugates that also have a Herceptin backbone that bind to the outside of the cell. But there are magic bullets, which I'll describe, that are actually linked to chemotherapy. And then finally, we have small molecule inhibitors. These are pills that actually target the inside of the cell here. And that's what you can see, all these different cancer signaling pathways. Ultimately, combinations are used and cause cancer cell death. This is a super busy slide, but I just want to give you an example in terms of what are all the trials that are out there that are looking at less therapy is more. Do we really even need chemotherapy in HER2 positive disease anymore? Or do we just want to use one chemotherapy for 12 times? So there's a lot of different clinical trials out there that are looking at a lot of these different questions. So I mentioned an antibody drug conjugates. That's that sort of magic bullet idea. So the antibody is the Y here that binds to the outside of the cancer cell. And then you can see these little pink things. That's actually chemotherapy that's linked to this Herceptin antibody. So it directly brings the chemotherapy to the HER2 positive cancer cells. So the antibody binds to the outside of the cancer cell, then it's internalized to the inside of the cell, and then it releases the chemotherapy directly to those cancer cells. So you're not getting as much of the toxicity throughout your body. And a lot of times patients who are on these therapies can keep their hair because it's not hitting your hair follicles. Here's another one that's made a big splash. This is called Enhertu. It also has a Herceptin kind of backbone, but it has a different kind of chemotherapy partner, which are these little orange balls here. And this has shown really impressive results in the metastatic setting. So I mentioned this idea of the chemotherapy linked to an antibody. You can see here, this little rectangle is the antibody binding there. You can see the pink chemotherapy now goes inside that chemotherapy, inside the cancer cell, into the nucleus, and causes basically down staging and decreased tumor growth. So TDM1 is Kadcyla. This was approved by the FDA in May of 2019, specifically for women with HER2 positive breast cancer that had residual disease at surgery after receiving pre-operative therapy. And you can see the results there. And this is also FDA approved. And you can see here that one area that still remains a concern in HER2 positive disease is disease that can spread to the brain. And you can see a difference there in terms of patients who had brain metastases. These antibodies don't really get up into the brain, and this remains a critical need. And these are some of the studies that looked at antibodies where you don't have uptake into the brain because we have something called a blood-brain barrier. So these large antibodies don't get up in there. And you can see that a lot of patients on the Catherine trial that were high risk had residual disease at surgery. They had resistant disease that recurred, and over half of those patients recurred with HER2 positive disease in the brain. So that's really an area that we're trying to get much better at. So this is a pill that is also approved in the early breast cancer setting, and it attacks on the inside of the cell. That's what these little yellow boomerangs are. And good news is these little boomerangs also can get up into the brain for a pill that you take. And this is approved both in the late stage HER2 positive setting, but also early stage in patients who are high risk after they've completed their year of HER2 therapy. Okay, and here's another molecule that's similar that has been approved only in the stage 4 setting that gets up into the brain. Here you can see that in 2021, very busy year for the FDA. I'm not sure where they got all the staff from, but you can see all the different agents that have been approved in that setting. And you can see that these are our NCCN guidelines in terms of what's out there. And then most recently, this was just presented at our big European Oncology Society at the end of September. And that other magic bullet drug, these are 2 head-to-head trials looking at those, and it showed pretty amazing results with an 80% reduction in the cancer coming back. So stay tuned. I think this drug is going to end up in earlier lines of therapy. The last thing I just wanted to say, it's almost Halloween here. This is Maleficent, and just to comment on another agent, which is a PARP inhibitor in the BRCA positive patients. And this has also been shown to improve survival in patients who have a genetically driven cancer. So I think I am probably out of time, and I will just save the rest of this for another time. Thank you.
Great. Thank you so much for that, Milana. I appreciate that talk and a great overview of many of the different therapies for breast cancer. So for the sake of time, I'm going to keep moving on and go ahead and talk about some surgical advances. So I wanted to talk a little bit about advances and innovation in breast surgery and breast reconstruction. So some of the trends that we're seeing in breast cancer surgery, and I wanted to kind of hit those at a higher level at a couple different ideas and trends. So the first one, we'll be talking to you a little bit about increased genetic testing and prophylactic mastectomy. You heard from Dr. Dolezal about de-escalating therapy from a chemotherapy, systemic therapy standpoint. We're also trying to do that in breast cancer treatment in terms of minimizing lymph node surgery, also trying to really push towards immediate breast reconstruction and then focusing on quality of life outcomes. So first, thinking about increased genetic testing leading to increased prophylactic mastectomy. So many of you may remember when Angelina Jolie announced that she had had prophylactic mastectomies as a result of having a BRCA mutation. And so one of the things that we're seeing is actually there really is an increased awareness of genetic testing. And you heard from Elizabeth about the guidelines. And what's pretty incredible to see is that we're seeing people who are hearing about genetic testing from some of the companies that, 23andMe and Color Genomics, and some of these that are really increasing access to and awareness of genetic testing. And then as a result, with things like Angelina Jolie and thinking about genetic testing, we're hearing more discussion around the option of risk-reducing surgery. And I think in many ways, having her have gone through this, it really allows us to hear kind of more widespread and open discussion about considering prophylactic surgery. And so when you look, you actually see that this is a group that looked at the actual impact of Angelina Jolie's New York Times op-ed when it came out in 2013. You can see there's a dramatic increase in rates of BRCA testing in the years following, and that trend has continued after her op-ed. And then additionally, when we look at the rates of mastectomy, we see a similar jump up in terms of rates of mastectomy. And so I think this again really tells us that this openness, this discussion around genetic testing and prophylactic mastectomy really allows more people to consider testing and then consider doing something about it if their testing is positive. So the way I think about it is really, know your risk, know your options. So thinking about if you are a person who has a family history, if you're concerned, really consider genetic testing within the guidelines, as Elizabeth mentioned, because this allows you to think about doing something active, being proactive about your health, and potentially considering risk-reducing interventions. Moving on to thinking about lymph node surgery. So when we think about surgical management of breast cancer, we have both lumpectomies and mastectomies to treat cancer in the breast, but then we also need to take a look at what's going on in the lymph nodes under the arm. So lymph nodes are usually removed as part of staging, meaning letting us know, has your cancer spread? And if so, how far is it spread? We also want to try to remove lymph nodes that are known to be involved. And over time, there's really been a major evolution from where we used to do a full axillary lymph node dissection. So it used to be that we were removing 25, 30, 35 lymph nodes, to now we can do a targeted lymph node biopsy where we put dye or tracer into the breast and it goes to kind of a gatekeeper set of lymph nodes, which is about 1 to 3 for most people. And that significantly reduces the risk of getting something called lymphedema, which is arm swelling that occurs as a result of moving lymph nodes. But we can actually kind of take this one step farther and try to think about what are other ways that we can reduce what we're doing for axillary surgery. So one of the new ideas that has come about is thinking about something called a targeted axillary dissection. And essentially, if we find that lymph nodes are involved with cancer during a needle biopsy, in some cases, we'll go ahead and give them chemotherapy or hormone blocking therapy to try to shrink the tumor, to try to make sure that we're getting treatment to the rest of the body so tumors don't spread. And there are actually multiple sites now that have looked at this in trials, and this is now really becoming the standard of care, that we no longer have to do this full lymph node dissection, full removal of all lymph nodes. Instead, we can just target the ones that were involved and go ahead and really minimize the amount of lymph nodes removed. And so this is just a schematic showing how we do that now, where we give the treatment, we see the response on imaging, and then we mark the lymph nodes that were involved and we make sure we take those out. So this has actually been a really big change in terms of how we think about treating people who initially present with lymph nodes that are positive. One of the other really amazing advances, I think, related to lymph node biopsy is thinking about doing what's called a delayed sentinel lymph node biopsy. So currently, if you're someone who has what we consider stage 0 or in situ cancer, you may have heard the term DCIS, ductal carcinoma in situ. If women are choosing to have a mastectomy with DCIS, we will often recommend doing this lymph node biopsy at the time of mastectomy, just in case invasive cancer is found during the mastectomy and when they look through it with the pathologist, and we would want to know about the lymph nodes for staging. What happens though, and is about 80 to 85% of surgeries, people have the sentinel lymph node biopsy, and it turned out they never needed it because there wasn't any invasive cancer found during the mastectomy. So there's really amazing new technology that allows us to put an injection into the breast, and these little markers there will actually stay in the lymph nodes that would be involved. We can then do the mastectomy, not to the lymph node biopsy, and wait to see what the final pathology looks like. If there isn't any invasive cancer, then people are done. And then they never went through a procedure that they didn't need. In the 10 to 15% of times that invasive cancer is found, then the tracer is still in the lymph node, and people can go back and have their lymph node biopsy done at a later date. Some other trends that have been really exciting to see are related to breast reconstruction. And as I mentioned earlier, it's Breast Reconstruction Awareness Day. And what's been really incredible to see, especially at a place like San Francisco, where we have a lot of plastic surgeons interested in breast reconstruction, is now we can typically offer reconstruction at the time of mastectomy. This can be done in a variety of ways, either with implants in 1 or 2 stages, with flaps where tissue is taken from one part of the body and moved to the chest itself. A lot of people will choose to have fat grafting, where small amounts of fat are injected either as a primary type of reconstruction or as an adjunct to other reconstruction. And then there's a new movement for people to be having what's called a flat closure, or aesthetic flat closure, which is basically where people are choosing not to have a formal reconstruction, but really still want to look good, to not have lumpiness or skin wrinkles or otherwise kind of strange contour to their chest. And so we're really learning as breast surgeons how to do what's called aesthetic flat closure, where we're able to carefully close the breast in people who choose not to have a formal type of reconstruction, but still have it look good. And this is just showing how immediate breast reconstruction is really on the rise over time. This is looking at private insurance and Medicare. And you can see that, in the last, these numbers continue to go up, but really now we're hitting a point where many women are offered the option of immediate breast reconstruction and all of the psychological benefits that come with that. One of the things that's talked about less is the idea of lumpectomy reconstruction. So essentially, if you do a lumpectomy, you remove the tumor, remove tissue around it. If you don't reconstruct that space, close that space with your own tissue, over time, you're going to get a divot. You're going to get a kind of this area of a hole essentially in your tissue that ends up getting indented and really can look pretty distressing for many people, especially after radiation. So what we try to do is actually close that space at the time of your lumpectomy. And we can also do this in a variety of ways that involve things like a breast reduction or breast lift. This for some people can actually be a true silver lining. So people who may always have wanted to have a breast reduction or a breast lift can actually have that done in the same surgery as the lumpectomy. Your breasts look better than you started, but it also allows you to have a really good reconstruction and to take the tumor out safely before going on to radiation. Hidden scar breast cancer surgery has also been a big thing to really think about, how can we minimize the negative impacts of what we do as surgeons? So when you look at these data, you see that a large number of women who've gone through lumpectomy surgeries are actually pretty uncomfortable with their scars. Certain pieces of clothing aren't worn because of scars. Women don't feel uncomfortable or don't feel comfortable when they're in a locker room or naked around other people. And it's really distressing. So what we try to do now is actually do what's called hidden scar breast cancer surgery, where for lumpectomies and mastectomies as well, we're hiding scars in natural creases of the breast or natural places where there's a color change to minimize the visibility of the scar. We can actually do this, I think, very well at this point. And oftentimes I'll have patients who've had a lumpectomy, they go get their follow-up mammogram, and the mammography technicians can't even find their scars. And that's one of my favorite things to hear, because it means that we've really thought carefully about how to minimize the impact of what we're doing. And this is just an example from the American Cancer Society website, which is a little distressing to think that this is kind of the expectation across the country, where really the expectation is we don't have any of this indentation. And instead we have a nice scar hidden at the edge of the areola and no indentation at the tumor site. So I think when we think in general about advances in overall cancer care, one of the things that we think about, of course, is that first and foremost, oncologic safety is important, but we also really want to optimize quality of life. So goals thinking about how can we minimize the negative impact of treatment and side effects? How can we really address the psychosocial aspects of treatment? You heard from Dr. Dolezal about potential side effects, sexual side effects, a psychosocial impact of treatment, and then really trying to do the very best job we can to help people in their cancer survivorship. So one of the ways we can do this is thinking about how to optimize quality of life after breast cancer surgery from a chronic pain and discomfort standpoint. So certainly with older techniques of mastectomy and reconstruction, a lot of people are having chronic pain. So some ways that we can address this, one is we're now doing over the muscle implant reconstruction. So we're not disrupting the chest wall at all, which really helps with a lot of the chronic pain that people were having. The second thing we can do is really try to minimize how much muscle, if any, we're taking when we're doing these flap reconstructions. So you may hear about things like DIEP flaps, which really avoid taking the muscle from the abdomen and instead just using the overlying tissue. And then also things like fat grafting or aesthetic flat closure, as I mentioned, can help decrease some of the pain associated with certain kinds of reconstruction. Additionally, we are developing nerve sparing procedures during mastectomies where we're not cutting into nerves, we're not injuring them, we're avoiding cutting them, and certainly avoiding traumatizing them in a way to try to reduce the chance that people have chronic pain, something called post-mastectomy pain syndrome that can occur fairly often after mastectomy, and then also trying to proactively treat chronic pain in people who do develop it post-mastectomy. Additionally, we're really thinking about things like the impact of surgery on body image, on sexual function, on intimacy, and again, just trying to support people getting back into their precancer life. Nipple-sparing mastectomy is a wonderful option for many people. It really allows people to keep the appearance of their breast the way it was before their surgery. You heard about oncoplastic surgery, hidden scar surgery, where we're trying to decrease the chance there's a divot or visible scar that someone has to look at every day and have a visible reminder of their cancer. We're trying now to go back after the fact in people who've had mastectomies and offer nerve reconstruction with certain kinds of reconstruction to help bring back sensation to the breast if you've already had a mastectomy. And then also doing nerve reconstruction during breast cancer surgeries with mastectomies to try to make sure that people do get to keep their sensation after mastectomy and aren't numb after surgery. And then really thinking through how can we support people? So from a psychosocial aspect, from a sexual function standpoint, how can we ask the right questions about side effects of treatment to make sure people are getting the support that they need? So in summary, I think we're really seeing kind of across breast cancer in general, whether it's systemic therapy, chemotherapy, medical oncology, surgery, we're really trying to do things that are tailored, that are less invasive, and that really reduce the negative impact of treatment in the hopes that we'll have better psychosocial and quality of life outcomes for everyone. So with that, I am going to stop sharing, and we are right at 6 o'clock, and I want to be respectful of everyone's time, but I just wanted to thank everyone so much from a faculty standpoint. Thank you for your fantastic talks. For everyone who joined us on the panel and as attendees and are watching this in the future, thank you so much. And Twin, of course, thank you very much for the CHRC support of our talk tonight. We really appreciate it.
Thank you for choosing to present for our community members. We really appreciate having all of you join us.
Great. Thank you again so much, Twin. Really appreciate it. And thanks, everyone. Have a good evening.
Bye.
Bye.
Thank you, everyone.